Hello, everyone. Happy New Year. This is going to be more and more people joining for sure. I'm confident this is going to be an amazing talk. Last one we were talking about 2 years ago, I attended was very informative. The audience here, especially the pathologists in the audience, are in for a treat. Dr. Gilks is a good friend, and he's a professor emeritus in University of British Columbia, and a consultant pathologist in their hospital in Vancouver General Hospital. He's a very prolific leader in the field of gynecologic pathology and breast pathology, women health as we call it now. And he's had over 450 publications, an amazing H-index of 115, very envious of that. And not only that, he's a leader in the field and has really moved the classification of ovarian cancer, helped move with many other colleagues forward. He co-chairs the WHO committee that was visiting that topic a few years ago. He's had many leadership roles, including he served as an interim chair in his department at certain time. It's as he should. He's been awarded many accolades that are well deserved, and he served as a president of the International Society of Gynecologic Pathologists, among many other roles. So it gives us a pleasure to have him here, and as we were saying, hopefully we'll have him physically here again sometime soon. And the topic of his talk is recent advances in the classification of gynecologic cancers. Thank you.
Well, thank you for that very kind introduction. If there's any challenges with the sound, let me know, and we'll carry on. In the next 40 minutes, we'll cover all gynecological pathology. We'll start with my disclosure statement, which you can see there in the world's smallest font. I'll give you 2 seconds to read that. Nothing to disclose, sadly.
I would recommend people turn their videos, so this way the bandwidth, so his voice would not break. So including myself, let's turn our video off and just listen.
I'll start with some wisdom from Steven Silverberg, who we asked him what were the most important discoveries of the last 50 years in gynecological pathology based on his extensive experience and academic career. And these were the top two: the role of HPV in the etiology of cancer of the lower genital tract, and the emergence of international classification systems for gynecological cancers. And this is my starting point because these two things figure prominently in what I'm about to discuss. And we'll go through, we have 5 sections that we'll talk about, 5 to 10 minutes for each. What's new for ovary? And the WHO 5th edition came out in 2020, and it's one of the things that Dr. Silverberg highlighted, the importance of having uniform diagnoses and diagnostic criteria around the world has transformed our specialty and helped patient care. But the 5th edition of the WHO Blue Book was largely unchanged from the 4th edition. It emphasized the 5 main ovarian cancer histotypes: high-grade serous, low-grade serous, endometrioid, clear cell, and mucinous. And the uptake was a bit slow after the 2014 Blue Book came out, but these are different diseases. They differ with respect to precursor lesions, risk factors, genetic events during oncogenesis. They have distinct immunophenotypes, patterns of spread, response to chemotherapy, and the patient outcomes are different. And that was a big change from earlier. Here's a quote from Sternberg's textbook of pathology. And we all thought that back in the day, but that actually has quite profound implications. If mixed carcinomas are common, then the histotypes must be closely related and the differences are unlikely to be relevant. And it's depicted here. We now know that this is not the case, and that we can subclassify ovarian carcinomas into these 5 histotypes And they reflect the underlying molecular pathology. You don't need to do any elaborate testing to know someone's going to be eligible for PARP inhibitors. It's a high-grade serous cancer, not a low-grade serous or mucinous carcinoma. And the classification rules are quite simple. We all see more endometrial cancers than ovarian cancers. To call something endometrioid of the ovary, it has to look like endometrioid of the endometrium. And the other big difference was tumors with an undifferentiated component, classifying them based on the differentiated part of the tumor. Only tumors that are completely undifferentiated throughout would be classified as undifferentiated. And they turn out to be an uncommon but special subset of ovarian carcinoma, as they are for endometrial carcinoma. And the problem, the historical problem, can be seen in these 4 slides, which are taken from a single, the images are from a single glass slide. So classic high-grade serous carcinoma, very characteristic appearance. These tumors do not have recurrent mutations. They're instead characterized by chromosomal instability with massive rearrangements of the genome at the chromosomal level, a lot of somatic copy number alterations and homologous recombination repair deficiency is a feature of many of these tumors. So the recurrent mutations, they all have p53 abnormal function, but BRCA mutations are the main other recurrent mutation that's related to the HRD deficiency. But in the same tumor, you might have glandular differentiation. We no longer call this endometrioid, this high-grade glandular differentiation. The solid also we don't call undifferentiated component. So that older practice of calling this a mixed tumor with high-grade serous endometrioid and an undifferentiated component, we no longer would do that in practice. We diagnose high-grade serous carcinoma. This patient will be eligible for BRCA 1, 2, and related gene testing, almost a 20% chance of having a germline mutation that allows testing of relatives with effective risk-reducing surgery. And also the new treatment of PARP inhibition has dramatically impacted outcomes for these patients with high-grade serous carcinoma, the biggest treatment breakthrough in decades. So the changes in the Blue Book, 5th edition, are relatively subtle. Mixed carcinoma, and you saw how it used to be very common. It actually was removed from the 4th edition, which was maybe a bit aggressive, but it turns out that they are rare, though, less than 1%. And they are typically admixtures of tumor types that are seen in association with endometriosis. And the most common is endometrioid and clear cell. Especially with mismatch repair loss, you get tumors with some variability in their morphology, including mixed endometrioid and clear cell differentiation. You should only diagnose mixed carcinoma when the 2 histotypes are unequivocally present. I like to say that if you can show it to the junior resident and convince them that there's these 2 components, that's when you would diagnose it. If you just have endometrioid and something that's a bit indeterminate, call it endometrioid. Same if you have obvious clear cell and something that's not typical clear cell, but not unequivocally endometrioid, just call it clear cell. Preferably, there should also be demonstration that the immunophenotype is different in the 2 components. So ER loss in the clear cell component or napsin A expression. And it remains the case that most carcinomas which look mixed from a morphological viewpoint represent a single neoplastic type with areas morphologically mimicking another tumor type. And for high-grade serous, it reflects the chromosomal instability. These are very, there's a great deal of intratumoral heterogeneity in these tumors, to the point where if you take 4 samples from a patient and do whole genome sequencing, only 50% of the mutations identified will be present in all 4 of the samples. The other changes, rare ovarian carcinoma variants now include the mesonephric-like carcinoma and dedifferentiated carcinoma for the first time. We are more familiar with these variants based on our experience with endometrial cancer, but they do occur in the ovary as well, and they're indistinguishable from their more common endometrial counterparts. Carcinosarcoma has lodged within the carcinoma category rather than being a true mixed epithelial and mesenchymal tumor. And seromucinous carcinoma is mentioned, but only to say that these are considered a variant of endometrioid carcinoma. The rare cases described as seromucinous carcinoma in the literature are molecularly and morphologically fit into the category of endometrioid carcinoma with some mucinous differentiation. So those are the changes for ovary carcinoma. It's also now in the 5th edition accepted that most high-grade serous carcinomas arise from the fallopian tube. And we show a serous tubal intraepithelial carcinoma here. The cells look like high-grade serous carcinoma. They're not subtle, with an elevated proliferative index, typically over 30%, but certainly over 10%, and with abnormal p53 expression, either overexpression or complete loss pattern. And new criteria for primary site assignment are included. These are also in the CAP checklist, so you're familiar with these. They don't affect treatment. One of the things that you see in the 5th edition of the WHO is that the criteria for diagnosis for tube, peritoneum, and ovary are all the same. And then assignment of primary site does not impact on treatment. It does impact on our approach to prevention, though, and we are soon, well, we have early data on opportunistic salpingectomy showing that it protects against development of high-grade serous carcinoma. And look forward to more follow-up data. This is an important niche finding. Small cell carcinoma of the ovary hypercalcemic type has frequent inactivating somatic and germline mutations in SMARCA4, protein encoded as BERG1. So small cell carcinoma is different than adult granulosa cell tumor. When we had a good molecular marker for adult granulosa cell tumor, FOXL2 mutation, what we found is that adult granulosa cell tumor had been overdiagnosed. What we found with small cell carcinoma, it's been underdiagnosed. So we have the small cells, but some of the tumors are entirely composed of these larger cells, and you perhaps can be forgiven for not thinking of small cell carcinoma in a tumor with this composition. But BRG1 loss, BERG1 loss, is found in a large majority of small cell carcinomas. So we have a good immunomarker. You can see from the box in the corner. It's also seen in some other tumor types, but the combination of BERG1 and Brahma loss, the two markers both being lost, is almost completely specific for small cell carcinoma. And we do use that in practice to confirm our diagnosis. It's a tribute to the expertise of the morphologists who first described small cell carcinoma, that they described all these variants in detail. But what happened in practice is that we only see these infrequently, and we were not recognizing them consistently in practice. And the final ovarian change is that we now know that there is genetic variation in sertoli Leydig cell tumors with 3 molecular subtypes. There's those that have a Dicer1 mutation, and this can be germline. These are younger patients. It's a moderately and poorly differentiated tumor with retiform or heterologous elements, and they should be referred for Dicer1 germline testing. They may have Dicer1 syndrome. The second are uncommon tumors with FOXL2 mutation that's seen in 95+% of adult granulosa cell tumors. These patients are postmenopausal, and they have moderately or poorly differentiated tumors, but never have retiform or heterologous elements. So the wide variety of differentiation that's associated with loss of dicer-1 function and proper microRNA processing is not seen in these tumors. And finally, about a third group, and these are about equal numbers of cases in our experience, have neither dicer-1 nor FOXL2 mutations, and it includes all of the well-differentiated grade 1 tumors. So work in progress to understand this fully, but we have some molecular subclassification and understand genetic basis of some patients' Sertoli Leydig cell tumors. So summary of ovary, minor changes without the major changes that we see, for example, in cervix and vulva. And it reflects our increasing understanding of the ovarian tumors, including the most common, which is high-grade serous carcinoma. So we'll move on to endometrium. What's new for endometrium? The histotypes are the same. And we have this understanding of endometrial cancer that was first laid out by a Russian gynecologist who recognized two different types of patients in his practice, those with type 1 and type 2 carcinoma, but it never really caught on in practice, and we now know why. The reproducibility is poor for high-grade carcinoma of the endometrium histotype diagnosis. This is a study did with Esther Oliva, Rob Soslow, and myself, and we only agreed about the predominant cell type in just less than 2/3 of cases, which is really not very encouraging. Very different than ovary, where we're very highly reproducible in assignment of cell type. And endometrial carcinoma, the molecular subtypes that the Cancer Genome Atlas identified in 2013 are now accepted to be a very important part of endometrial cancer. So ovarian cancer, morphology alone declares the molecular subtypes effectively. In endometrial cancer, it didn't work out that way. So you have to use molecular testing to identify the 4 groups, starting with sequencing for exonuclease domain mutations in POLE, immunohistochemistry for mismatch repair deficiency, works better than microsatellite testing as a screening tool for endometrial cancer, which is a bit different than colon cancer. And then P53 immunostaining, which is an excellent surrogate for TP53 mutation. And what's left is this no specific molecular profile group. Just over 50% of cases fall into that group. These 4 molecular subtypes of endometrial cancer are like the 5 histotypes of ovarian carcinoma. They occur in different settings, differences in pathogenesis, different genetic risk factors, Lynch syndrome versus hereditary breast and ovarian cancer syndrome and some P53 abnormal endometrial cancers, different precursor lesions, different prognoses, different responses to treatment, for example, hormonal therapy for conservative management and retention of fertility is probably only appropriate for the NSMP. And we can diagnose them accurately based on biopsy. So all of these things mean that we're in a transition. We're looking at introducing this into practice. It will guide therapy, for example, the decision to give platinum taxane chemotherapy or immunotherapy. Our clinicians are interested in it. And in the case of the POLE mutant tumors, it can guide a decision to de-escalate therapy, which saves toxicity for the patient and saves cost as well. So all of this is work in progress, randomized clinical trials underway to substantiate the findings of the PORTEC-3 trial, which showed a predictive value to molecular subtype diagnosis in terms of guiding adjuvant therapy. But how does this impact on our current practice? How do the molecular subtypes relate to histotype? Well, it turns out that, as we might have expected, the low-grade endometrioid are mostly NSMP, but does include some others, including up to 5% P53 abnormal. High-grade endometrioid are really a mix. There's no one molecular subtype that predominates, but the largest group is the mismatch repair deficient. Serous carcinoma, almost all of them are P53 abnormal, with just a few mismatch repair deficient polymutant. But when you turn that on its head, for the P53 abnormal, the worst prognosis group, the one that's show a definite response to chemotherapy and PORTEC3, what percentage of those are serous? It's only about half. So histotype is not a substitute for molecular subtype. Histotype does not provide additional prognostic information beyond molecular subtype in most studies so far. Larger series may show something within some of the groups, especially the NSMP group, where NSMP, you have to make sure you've taken out the mesonephric-like or the clear cells, for example. But molecular subtype is here to stay. This diagnosis based on surrogate markers of genomic architecture can change patient outcomes and improve patient outcomes. In terms of reproducibility, for biopsy versus hysterectomy, a kappa statistic of 0.86. In a single case where the biopsy was not representative, the dedifferentiated component was not present, then the correlation was not there, but otherwise it was. And that's true of any of our pathological assessments. So it was not a problem with molecular subtype diagnosis, it's a problem with the sampling. Just a reminder, endometrial biopsy is only about 90% sensitive for diagnosis of endometrial carcinoma. So if you do an endometrial biopsy of the patient who is subsequently proven to have endometrial carcinoma, on the first pass, you'll only pick up 90%. It seems more sensitive because we have a lot of negatives in our practice, and they're true negatives. But the sensitivity consistently runs about 90%, and it does not guarantee that you're going to get a representative sample of tumor. This kappa statistic, though, is far better than the biopsy versus hysterectomy correlation for grade or histotype, where there's quite a bit of change between biopsy and hysterectomy. So mismatch repair deficient, it's there as an early change. Polymerase epsilon, exonuclease mutation, same thing. P53, same. In terms of the inter-laboratory and inter-observer reproducibility, the kappa statistic was excellent. What we found is mismatch repair interpretation at one of the sites. They didn't have experience. They were just starting, and they misinterpreted weak MSH6 staining as intact staining. It was very weak compared to controls, and they were being a bit obsessive. It was not normal staining. So there was an educational component that was necessary for them to interpret mismatch repair correctly. The other problem, in a different lab, their P53 immunostaining, the technical quality was not good. It was very weak, and they were having trouble distinguishing wild type from complete loss pattern, which is a big and important difference. So excellent reproducibility, but the opportunity for better with improved quality assurance measures. So that was very encouraging. And if we go back to the type 1 versus type 2, it's true that most type 1s are endometrioid, grade 1 or 2, most type 2s serous, and some clear cells, which we think are probably the P53 abnormal clear cells. And then the endometrioid grade 3s are really a mix. And it's why type 1 and type 2 didn't work in practice. There were too many cases that fell between. And in terms of the molecular subtype, you see down below NSMP, mismatch repair deficient spread across all 4 of the histotypes. P53 abnormal across all 4 of the histotypes. The big thick bars, thinner bars, and thin lines and dotted lines are reflecting the percentages, from low percentage of cases with dotted lines to majority with the very thick lines. So it does show the relationship. And what I found in practice is that for the first time, I get these high-grade endometrial cancers and they're soluble. Oh, that's a mismatch repair. That's why it has unusual morphology and is hard to histotype. Well, that's a p53 abnormal. That explains the high-grade nuclear features. And polymutant with the prominent lymphocytic infiltrate and high-grade cells showing up in an endometrioid carcinoma. And it's much easier. The old way of showing it with Phil-Clement, and we take our best guess at histotype, gives way to confident assignment of molecular subtype. So the summary of changes in the endometrium section of the WHO 5th edition, there's emphasis on the 4 molecular subtypes of endometrial cancer. And this carries forward into subsequent clinical guidelines, more in Europe than in North America at this point. There's also inclusion of carcinosarcoma as a variant of endometrial cancer. And these are, in a large majority of cases, p53 abnormal. They should be included in clinical trials. They've been excluded or they've been grouped with sarcomas. That has not advanced the cause for our patients with carcinosarcoma. If p53 abnormal is a marker of response to platinum, and the number needed to treat is about 5, so if you treat 5 patients, you will save 1 life with the, based on the data in PORTEC-3, huge opportunity with carcinosarcoma that's been missed up until now. We have to validate that prospectively, but still it's a very impressive ability to take a common chemotherapy that our clinicians are very experienced with and use it in this scenario for a tumor where we need good adjuvant treatment. And finally, recognition of new entities, mesonephric-like adenocarcinoma and gastric type adenocarcinoma arising in the endometrium. I won't say much more about them, but they're fascinating. There is an opportunity to gain more knowledge. They both look low grade, but behave very aggressively, and look forward to reading papers about them in the coming years. What's new for uterine mesenchymal tumors? So in 2014, WHO did have high-grade endometrial stromal sarcoma coming back into the classification system. Because of this, YWHAE, not M2, fusion, high-grade endometrial stromal sarcoma, first described by my colleague Chang-Han Lee. And this is it was a fun time because Chang-Han would present on these cases and you'd see all of the senior gynae pathologists going, oh, I've seen one of those. And they were common enough. In 2020, we have a new high-grade ESS, and these are the B-core related ESS, less common, and they're a spindle cell neoplasm with myxoid features. And I think in the past, we would have diagnosed these as myxoid leiomyosarcomas. They have an aggressive clinical behavior, thus they belong in the high-grade category. Arguably, a diagnosis of myxoid leiomyosarcoma is not such a bad thing because it doesn't change management. But the only way you can change management is to have a proper diagnosis reflecting the underlying biology and then proceed with clinical trials of some sort of targeted therapy. So it starts with us in pathology. And we should make every effort to diagnose these correctly. So the X22 translocation with B-core driving oncogenesis, first described by 2 cases by Panagopoulos, then my colleague Lin Hong in 2017. This is a little out of date. There's been more reported cases since I made this slide up, and we also have the internal Tanner repeats of B-core. Let's look at the cases reported by Panagopoulos. And variable appearance, here's a more myxoid, less cellular area with ER and PR positivity, more overtly high-grade area, ER, PR negative. it's like the YWHA translocation cases. There's significant intratumoral variability. Pushing and worm-like invasion, very characteristic of endometrial stromal sarcoma. So when you get to a higher power, you see that it's not a typical low-grade ESS. This is present in most cases, this infiltrative margin, if you have a chance to see the margins and evaluate them. The myxoid quality that we talked about, you can see why this might have been called a myxoid leiomyosarcoma in the past, including vesicular growth. The chromatin is uniform, inconspicuous nucleoli that's not a undifferentiated endometrial sarcoma, but brisk mitotic activity. It is a high-grade tumor. B-core immunostaining, and both fusions and internal tandem repeats can be picked up molecularly. And these tumors do belong in the endometrial stromal category based on what I showed you, but also the molecular abnormality. These are translocation-driven sarcomas, and B-core is part of the polycomb repressive complex. And it's an attractive target for treatment, given that it's also involved in the genesis of low-grade endometrial stromal sarcomas. We have recently described uterine sarcomas, the end-tract fusion uterine sarcomas, and these unusual cervical sarcomas that have a fusion that's seen in dermatofibrosarcoma protuberans of the skin. Also, almost all of these cervical. So these are from Sabrina Croce's paper in 2019 in Modern Pathology, fibrosarcoma-like with some plastic cells, tract immunohistochemistry positive. PCOMA, term introduced in 1996 for perivascular epithelioid cell neoplasms. They're in the WHO, remain a challenging diagnosis. So pleomorphic, they express muscle markers, but co-express melanocytic markers. Here's HMB45, melan A with just a few positive cells. You see one in the center here. And that's the problem. In 44% of PCOMas, there's less than 6% of cells staining with both HMB45 or melan A. That's not being very clear here, but it means that 5% or less of cells stain for either of these in almost half of PCOMas. That very focal expression is a real problem for recognition. And Desmond, not specific. Microphthalmia transcription factor, not specific. So the presence of clear cells or HMB45 positivity in a conventional smooth muscle tumor shouldn't warrant a diagnosis of PCOMA. So how do we make the diagnosis? Olufadari has said that the distinction should be a largely morphological exercise, whereas Dr. Schoolmeester has come out in the appropriate morphological context. Focal staining with melanocytic markers and one muscle marker supports the diagnosis. And these are not contrary views, but they together tell us that this remains a challenging diagnosis. You have an index of suspicion, you suspect it morphologically, and you look for the confirmatory immunostains, knowing that the melanocytic marker staining may be quite focal. The criteria for malignancy are in evolution. You look at these features: size, grade, necrosis, vascular invasion, margin, mitotic index. Benign if you have 0, uncertain if you just have nuclear pleomorphism, size greater than 5 centimeters, for example, with more than 2 features, malignant. So 2 or more features, malignant. So it remains a problematic diagnosis. So summary of uterine mesenchymal section of the WHO 5th edition. Numerous gene fusions have been identified in endometrial stromal neoplasms, and it's allowed for well-defined subsets of high-grade endometrial stromal sarcoma to be diagnosed, including those with B-core rearrangements, new edition. And we await this being translated into improved treatment and better outcomes for these patients who are in need of better treatment than surgery alone, given the high rate of relapse and subsequent mortality. Inflammatory myofibroblastic tumor with ALK translocation, PCOMA. What we used to do, calling everything leiomyosarcoma, is giving way to a much more sophisticated diagnostic approach. And the paper I mentioned, Dr. Sabrina Croce's in 2019, in Modern Pathology, it's a very nice algorithm at the end, one of the figures that can guide you through muscle markers, ER, CD34, ALK to get to where we should be. But if I could summarize one thing, if you have any myxoid change, stop before just signing it out as leiomyosarcoma. It could be inflammatory myofibroblastic tumor or B-core rearranged tumor. What's new in uterine cervix? We have an etiology rather than cell type based classification. We were almost there in 2014, but didn't make the jump, unfortunately. We still had, up until 2020, classification that was what the cells looked like. It was biloglandular, endometrioid, or mucinous, and completely random diagnoses in different centers. That's not the case anymore. And there's emphasis on the 15% of tumors that are HPV independent, which could be gastric, clear cell, or mesonephric. These appear to be truly mesonephric rather than mesonephric-like, and that we often see mesonephric remnants associated with them. So here's a glandular abnormality on colposcopy, unusual appearance to the cervix. And these are fascinating tumors. These gastric-like adenocarcinomas, a subset of which were diagnosed as adenoma malignum. Here we have it in the wall or adjacent to the wall, the thick wall vessel, which is a feature of invasive endocervical adenocarcinoma. There is some stromal response around these glands, but look at the glands. So bland, low mitotic count, but this is an aggressive adenocarcinoma. And we don't use the term adenoma malignum except descriptively. We now know that these are gastric type adenocarcinomas of cervix, HPV independent cervical adenocarcinoma. And often there's more diagnostic, higher grade components, but there may not be. And the superficial biopsies of these lesions may be misdiagnosed as benign, sometimes several times before a larger sample comes that shows deep invasion. So the summary of changes in the uterine cervix section. So most endocervical adenocarcinomas are HPV associated, and we're not really good at stratifying those further prognostically. A significant minority are not. And I'm already seeing the radiation oncologists choose to treat these ones differently. They're saying that these are not radiosensitive to the HP independent, whereas the HPV associated squamous or glandular lesions are radiosensitive. So it is impacting on treatment. And we should divide the HPV independent into specific types. And finally, we'll finish off what's new for vulva vagina tumors. And it's the same, back to what Dr. Silverberg had identified, this discovery in the late part of the last century of HPV and its causal role is now impacting on practice. And again, it's starting in our center to impact on patient care management in a quite striking way. So we diagnose as HPV associated or HPV independent, both the in situ or precursor lesions and the invasive carcinomas. And these are the categories from the Blue Book. HPV versus non-HPV, differ age, etiology, precursor lesion, biomarker expression, patient outcome. And like what we saw in ovary, endometrium, cervix, different diseases, but this time etiologically classified, like for cervix adenocarcinoma. HPV-associated vulvar squamous cell carcinoma, HSIL to use last criteria, giving way to invasive squamous cell carcinoma, often a basaloid or warty type, but doesn't really matter. We tend not to give those descriptive terms when we sign these cases out. But here it is, often quite uniform cells, can be missed if you're not looking for it, but dysmaturation with parakeratosis, high mitotic rate, including mitoses off the basal layer, and P16 positivity, block positivity, extending up to at least the lower third of the lesional squamous epithelium. And you see here how P16 fades out as you get higher up within these, a little bit different than cervix. P53 often shows this basal sparing pattern. It's not mutant, it just reflects the biology with the HPV encoding a protein that binds to and inactivates P53. So don't be misled by this pattern. This is wild type, but completely characteristic of HPV infection, where the basal layer does not stain and the more superficial cells show variable staining for P53. HPV-independent vulvar squamous cell cancer. This pathway differentiated VIN through to invasive squamous cell carcinoma that's often well differentiated, but may be high grade. And these are the criteria from 20 years ago for diagnosis of differentiated VIN or DVIN. Epidermal hyperplasia with parakeratosis and elongated and anastomosing reedy ridges, significant basal cytological atypia, and they did make mention of cells with abundant eosinophilic cytoplasm. So we dutifully take a picture of something like this to illustrate for a textbook or show you in your residence. And you can see the basal atypia and the downgrowth of cells with atypia. And this is easy enough to recognize. The trouble with those criteria is not their specificity. They work well. If we call something DVIN, it's a precursor with high risk of progression to invasive cancer. It's the sensitivity. We miss significant HPV-independent precursor lesions if we stick to those criteria. Now, the molecular abnormalities can be an aid in diagnosis of DVIN, and that P53 mutation is present in most cases. And this is manifest with immunostaining as increased basal expression, but it can be subtle, or complete loss of P53 expression. So here we see an abrupt transition from wild type to overexpression. And when you have the transitional area, that's pretty easy to interpret, not so easy on a small biopsy. Here's the subtlety of DVIN. So does it meet the Yang and Hart criteria? Maybe not, but you do see normal maturation, abnormal maturation, big pink cells. Not much atypia though, is there? And complete loss of P53 immunostaining, and it does bring out the nuclear atypia when you have just the counter stain in this P53 immunostain slide. This is differentiated VIN. So P53 overexpression in DVIN is subtle. It may be difficult or impossible to distinguish from normal pattern unless there's marked atypia or adjacent normal epithelium for comparison. So you have to use it with some caution in small biopsies, but I do believe that with practice, we are getting better at diagnosis of DVIN and interpreting P53 immunostaining. But there is another pathway, and this appears makes a touchdown in the 5th edition of the WHO, but a lot more attention on it over the last year or two. And this is the one with p53 independent pathway to vulvar squamous cell carcinoma. And we have this terminology from individual papers: differentiated exophytic vulvar intraepithelial lesion, or DEVIL, vulvar acanthosis with altered differentiation, vulvar altered maturation, giving rise to a very well differentiated keratinizing squamous cell carcinoma. These atypical, often verruciform lesions aren't deviant. They don't have significant atypia. So the precursor lesions, p53 mutant, higher grade, worse prognosis, associated with classic DVIN and abnormal p53 staining, in contrast to the p53 wild type or p53 independent pathway. These verruciform lesions can be identified based on exophytic with prominent acanthosis of verruciform architecture, lacked features of HPV. They didn't have coilocytic atypia, negative for P16 or in situ hybridization, but they lacked significant basal atypia, so you couldn't really diagnose DVIN. So let's show you one case just to make the point here. This lady comes in with a lesion. She's a difficult operative candidate, Down syndrome, quite profound mental retardation. Couldn't take a biopsy. They excised the lesion. We have normal squamous epithelium giving way to lesion here. And you can see very acanthotic and verruciform, more bulbous downgrowths, almost looking like verrucous carcinoma here, but no real atypia, but it does have the big pink cells. And there was focal invasion at the base of this. So a number of lines of evidence suggesting that these atypical verruciform lesions are in fact precursor lesions, low grade, p53 wild type immunostaining pattern. The biopsies in these can be really challenging because they're small and superficial, and p53 doesn't help. And correlation with the clinical appearance can be really important. So we had this lesion here. Clinically, it was diagnosed as lichen simplex chronicus in a small biopsy. And this is not lichen simplex chronicus. This is a clonal outgrowth of squamous epithelium. It's overgrowing, but it's not in response to anything. It's a neoplasm. When this was removed, it was predominantly HPV independent VIN, but there was focal invasion. It had been neglected for 2 years because the biopsy said it was benign. And we see this with an unfortunate frequency. So this new field with the HPV independent VINs, where we're pushing the margins, more likely to diagnose these. There's remain challenges. If you have a challenging squamous overgrowth type of picture, call a clinician. Is it well demarcated, solitary, no precipitant? Well, a lesion like this should come off. Our gynecologist would take this off. It doesn't matter what the biopsy shows, but for a general gynecologist, they may need some encouragement to do so. You have to look at the whole lesion to get an accurate diagnosis in these still. So it remains a work in progress for the HPV independent VINs, and in particular the ones that have no p53 abnormalities. So HPV independent VIN, we think, is going to end up as being either p53 wild type, p53 abnormal, and that will eliminate these morphological descriptive diagnoses here. And those will be the two subsets of HPV independent VIN, with this one more aggressive than this one, but ultimately with the potential to lead to invasive cancer, the p53 wild type more likely to be a low-grade or verrucous carcinoma, p53 abnormal more likely to be low-grade or can be high-grade squamous cell carcinoma. One last point is that these can progress, acquire a p53 mutation over a course of time and become quite anaplastic over time. We've seen that progression from what's ostensibly a low-grade lesion to a very anaplastic carcinoma. And we know that that happens with verrucous carcinomas sometimes, for example, if not adequately treated. Progression to poorly differentiated carcinoma. Used to think that it was due to the radiation therapy. We think now that radiation therapy is ineffective, but it's not a cause of the progression. And just one reminder, although I talk about these as being low grade, these HPV independent lesions are low grade cytologically compared to H cell. Here's someone who has nothing visible, no biopsy taken, then in 3 months has a large exophytic mass. It's an invasive squamous cell carcinoma. They don't behave in a low-grade fashion clinically. It turns out that the ones that are more low-grade histologically are more aggressive clinically, and we have to be mindful of that. We also saw that with cervical adenocarcinoma, the HPV independent lesions being the more clinically aggressive lesions, and the ones where we must focus our attention if we're to improve the natural history of patients who are diagnosed with this disease with new treatments. So in summary, vulvar squamous cell carcinoma is now classified into HPV-associated and HPV-independent types, and the latter has a worse prognosis. It's done based on clinical findings, morphology, but mostly on P16 immunostaining. Most experts say you should do this at least once and make that distinction because you can be fooled based on morphology or clinical setting. And you can interpret your P16 better if you choose to stay in a section that shows in situ disease. That shows the block basal staining that's a surrogate for HPV infection, high-risk HPV infection. So with that, I will end. Thank you very much for your attention. I'd be happy to take questions now. I'll stop sharing my screen.
Thank you very much. A lot of grounds to cover. So we can either post questions or feel free to raise your hand and talk if you have any questions.
I was going to ask some question. This is Andrea Khan. So thank you. That was an excellent summer review. We deal with all those changes and findings all the time. But I have one question about the endometrial biopsies. You mentioned about the accuracy of making a diagnosis and grading those, and that's true for the most part. One question I have is on endometrioid lesions, things that look like possibly a high grade. We had cases where resections end up being, low grading, if you wish, FIGO 2 or something like that, and the biopsy was called somewhere FIGO grade 3. And so what's your opinion on that, and what hint can you give us on situations like that?
That happens with some regularity because FIGO is based on assessment of the entire lesion. You have just a little bit to look at in biopsy. It's not surprising that the percent that's glandular can change. So that frustrates our clinical colleagues, our surgeons, but that's inevitable. It's the nature of grading. What we do find, though, is that the molecular subtype, so you do mismatch repair, you get it on the biopsy, and you transmit that information. And if you move towards doing P53 routinely, that will pick up these aggressive ones, whether they're endometrioid or not. So if we move away from depending on FIGO grade to molecular subtype, it's great because when the grade changes that way, and it very legitimately does change when we apply the criteria, it doesn't change. It's not a change that will impact on the decision to make decision about surgery or subsequent chemotherapy. So I see a better world than what we've had up until now, where you have the biopsy, you regretfully end up changing it significantly based on the hysterectomy in a way that if they'd known in advance might have changed their operative approach. But nothing we can do to change that right now. I think the way out is to move towards molecular subtype diagnosis.
Thank you very much.
I have a question. This is thank you, Dr. Gils, for the wonderful talk. You know, the P53 is most of the times easier to interpret because of diffuse and strong staining. You can call mutant pattern or null pattern. Have you come across cases where it's not like wild type, but there's some areas are strongly and positive? And then if you follow that 50%, 70% criteria, and then you get confused, is it really mutant pattern or not? And we recently had few cases like that and didn't know how to deal with it.
Absolutely. This has been, I like immunostaining. I like the challenges it presents. And you've identified two separate challenges. One is where there's subclonal staining patterns, where the staining is different in two areas. One, okay, I'm comfortable with that being mutant. The other part, I'm not so comfortable. It appears like it could be wild type. There's two possibilities we see in those cases. That's a common finding to be associated with polyexonuclease domain deficiency or mismatch repair deficiency. So the first thing we do is to see if it's one of those, because in that case, the P53 abnormal pattern is a secondary event. And they behave, unlike P53 abnormal, they behave as either really good prognosis or okay prognosis. And that accounts for about half. The other half, we've sequenced carefully the two different components, and they're both mutant. So it's truly a P53 abnormal once you've eliminated the other possibility that it's a mismatch repair deficient or polyexonuclease domain. We're lucky when we come across something and we just aren't sure whether it's high wild type or mutant pattern, we sequence it. But you know, we don't have to sequence very many anymore. That really works well. And we see fewer cases in endometrium than ovary where it's got a mutation, but the immunostaining pattern anybody would call wild type. And that happens with mismatch repair deficiency too. You can have someone with Lynch syndrome and their mismatch repair staining sadly is intact. It's not common, but it's a failing of looking at the protein. But in endometrium, it's worked really well for us once we get past exactly those issues that you have identified.
So a secondary question, in that scenario, do you think P16 staining, because people do P16 in these, especially endometrial lesions, if the P16 is diffusely and strongly positive, and this is, I'm talking in a setting of no solid area seen, like where you're getting confused, is it in pseudo endometrioid like serous, and P53 is not helpful, would you think P16 would help? Or because sequencing we can do, I think, but we usually let clinicians order that. It doesn't come from our end, which, yeah.
Yeah, P16 I never use in that context. I don't have confidence in it, either with our validation or with what I've read. It's not the tight correlation with mutation that we see with P53 immunostaining. So I don't see it as being additive. I see it used in ovary and do use it in ovary if something looks like a low-grade serous and P53 wild type, sign it out. It looks like a high-grade serous, P53 wild type. Wait a second, maybe a couple %. of these will have a mutation in P53 wild type, then I will do a P16. But endometrium, I'm just too nervous to trust the results. So I do not use P16 in that context.
Thank you.
Personally.
If for 1 minute, there's another minute I can ask about MMR staining. As you just mentioned, you know, we have case, if you follow the CAP criteria, which is 1% cutoff, I have seen cases where it's like, if you really look hard, you will see some tumor cells showing staining. But most of it, most of it's lost. And I believe that those are, you know, those are MSI tumors. It's not intact, even though it's greater than 1% of tumor cell staining. So, you know, I'm saying the cutoff, like even though the CAP says 1% cutoff, do you have a higher cutoff, like 5% or 10%? Or it seems we have an MSI testing here, but we were told it's not very good for endometrial tumors. So what do you do in such cases?
Well, first, I don't think a numeric cutoff works. And I think it's true for P53 as well, that the way you set up your stains in your own lab will influence how you interpret them. But if there is profound reduction of staining for what is normally a very strong stain like MSH6 in our hands, that's abnormal. And we've done this often enough. We did an audit, 500 cases we went back, and pathologists have this reputation for being very obsessive. But it was gratifying that every one of these, when you looked very obsessively and you saw a few cells positive, they'd been interpreted correctly by the pathologist of the day. So it was not causing a problem, but that weak staining, you're right, that's not normal. It's less than the control cells, which are not as rapidly dividing. The biology is not there to interpret that. So that's something that we do emphasize, that we want to interpret it in the context the way we would other immunostains, and we do not advise using a numeric cutoff. Or in the old days when we started doing it, it was like, if any staining, it's positive. Remember those days? Well, we're better at interpretation than we used to be.
That's very helpful. Thank you very much.
Thank you very much. And before Deputy, you think of another question, we'll have to end there. We appreciate you're taking the time. This was very informative, I'm sure, to a lot of the people on the call. And we hope to see you in person soon.
Yes, very, very much so.
Thank
you very much for the invitation.
Thank you.
Thank you.